you guys, it's Dr. Baker Townsend, and we're just going to do a brief review of what you learned in anatomy and physiology about conception and fetal development. Here are your learning objectives. We're just going to look at fertilization, the development of the placenta, amniotic fluid. We're going to talk about it for a moment. Look at the changes as the baby goes from an embryo to a fetus. We're going to talk about teratogens and what that means, and if you are exposed to a teratogen, what that means to the patient during the specific time of fetal development. So here's the sperm, here's an egg. You need a sperm and an egg for fertilization. So once there is fertilization, there becomes a reaction, and then the egg becomes sealed off so that more than one sperm should not be able to penetrate the egg. Gametogenesis, oogenesis is the process of the egg, the ovum formation, and spermatogenesis is the process of the sperm, obviously. The ovum, which is the egg, lasts for about 24 hours. You need sperm, that lasts for 72 hours. So theoretically, you can have intercourse within 72 hours of ovulating, and then you could still have some viable sperm. There are some studies that some sperm can live up to 5 days. So this is why we're very cautious when people are trying to avoid pregnancy by having them abstain 5 days prior to ovulation and 5 days after ovulation. Sperm, they have capitation, and that's the removal of the protective coating so that they can inject their DNA. So the male is responsible for the sex of the embryo. Zygote is the first formation. A morula is 16 cells, and then the blastocyst has a trophoblast, and that looks like a placenta. You can see an ovum, and you can see a placenta start forming and fluid. Implantation occurs 6 to 10 days after conception. We're going to look at a fallopian tube here in a second. And once we have implantation, there's establishment of chorionic villi into the decidua basalis, which is actually the endometrium of the uterus. So every month you shed your endometrium during menses, or the endometrial lining. But if you became pregnant, that endometrial lining stays the entire time of the pregnancy. Hence, you do not have a period when you're pregnant. And that is now called the decidua basalis. After delivery, you will shed this decidua basalis, so it is clinically a menses. So once we have an embryo, the primary germ layers of the ectoderm are the ectoderm, the mesoderm, and the endoderm. The embryo is from day 15 until 8 weeks. So when we say embryonic, it's from conception until 8 weeks. It's the most critical time of development. This is when the midline is forming. This is when major congenital abnormalities can occur. And so we do not want mom exposed to any teratogens. And a teratogen is something that could change the congenital structure of the baby, or change the structure of the baby. A teratogen is something that causes abnormal development. Classic teratogens are retin-A. Birth control pills can have a teratogenic effect. Dry cleaning fluid, pesticides, lead, alcohol, major alcohol use. So we worry about those type of teratogens. We can see here's fertilization. So fertilization occurs actually in the tube. While the egg is maturing, we can see here's an ovum that turns into a primary oocyte, or an egg, and then it is expelled right here. As it grows, it's going to expel about halfway through the cycle, and then now this egg is going to go into the fallopian tube, and that what was around the egg is now called the corpus luteum. So now you have this corpus luteum that will continue to encourage the ovary to secrete estrogen and progesterone until the placenta takes over after the first trimester. So when people ovulate and they don't get pregnant, this degenerates and dies. But when people do get pregnant, this corpus luteum continues to increase progesterone especially, but estrogen as well, to support the pregnancy. So you can see once there's ovulation, then the egg comes here. There's fertilization in the tube. You have peristalsis and cilia, which are going to push this fertilized ovum down this tube. And so you can see fertilization in about 24 hours. You have cleavage, which is 2, which is a split, egg. It looks like 2 cells. The merolla is about 3 days. And then you're going to have a blastocyst. This one we really start to see that there's major changes, and it's going to implant in the endometrial lining, which is now called the decidua. Implantation is from 6 to 10 days. And when this fertilized ovum, it's going to implant into this endometrial lining, this is a lot of blood supply. And you can see this is an implanted ovum, or implanted new pregnancy after fertilization. And you can see this is all blood supply. These are the uterine glands. So there's a lot of spotting. You can have spotting. A lot of people will say, I missed my period. I had this little spotting that happened a few days before I was supposed to get my period. Then I missed my period. That's usually this implantation bleeding, because it goes into the endometrium, and then it breaks some of these terminal capillaries, and then there's blood. You can see that. So here it is. It's implanted. It's getting oxygen and nutrients from the uterine lining, and this will continue to take place until the placenta takes over at the end of the first trimester. The embryo and the fetus. So there are 2 membranes surrounding the embryo. One is the chorion, and the other is the amnion. I'm going to show you a picture in a second. And then there's going to be amniotic fluid. Let me just skip along here to this one. So you can see here's the baby. This is all amniotic fluid right here. And in the cavity, you can see this is early on. This is just the little yolk sac and connecting stalk. Then it's going to grow, okay, and you can see how this placenta is really starting to form. And you see there's just a little head and tail. This is just a very small embryo. And you can see here's the amniotic fluid. And then this is a mature, this is a fetus. And so you can see that there is the amnion, and that is on the inside. There's 2 layers. The amnion is on the inside, and then there's another layer, and that's the chorion, and that is on the outside. So there's 2 protective layers that prevent babies from getting exposed to viruses and bacteria vaginally, right here. You can see amniotic fluid, and then here's the cord and the fetus. Let's go back to this real quick. So what does amniotic fluid do? Well, it provides many functions. The first one is warmth. Babies do not have to regulate their temperature when they're in utero. So when they come out, it takes them 3 to 5 days for them to convert from non-shivering thermogenesis to being able to regulate their temperature. So while they're in utero, they're warm. They're not thinking about trying to establish warmth, but after they come out, we really have to be cautious on making sure they don't get cold, because it takes a little while for them to get used to it. Also, the amniotic fluid prevents contractures. The fluid allows them to float. Let me go back to this one. See how they're floating there? So there's nothing pressing on their arms, pressing on their legs. So they can grow and develop easily because, they're floating in a ball of fluid. Movement, it allows them to have movement, to grow, and then respiratory and renal development. These are very important. Babies breathe in the amniotic fluid to increase the strength of their lungs and to mature their lungs. So if we have decreased amniotic fluid, we know we can have respiratory complications. Also, renal development, they drink the amniotic fluid and then they urinate it out, and that helps their kidneys to develop. Volume is super important. Oligohydramniosis too little, oligo obviously, and that could lead to respiratory and renal development, contractures, all of these things. And then polyhydramnios, or too much fluid, can tell us there could be some type of renal problem or renal issues because they have too much fluid. We've already looked at this one. You can just kind of go over this again. Inside, their yolk sac is very early, first 5 to 6 weeks, and then you're going to have, let's go back to this picture real quick. You can see that this is a yolk sac, and it's just really early. And then you're going to have your cord is going to lengthen, and you're going to have a fetus and a cord. So let's look at the cord. So the cord, this is it. This is a very impressive cross-section of an umbilical cord. It has 2 arteries, and I always say it kind of looks like a face, but there are 2 eyes, these 2 tiny little arteries. What they do is they carry back CO2 and waste from the baby to the placenta. By diffusion and osmosis, mom picks it up and takes it and gets rid of it. They have one huge umbilical vein, and this is it down here, and it supplies the baby with oxygen and nutrients. Now there's this substance that surrounds all 3 of these vessels, and it's called Wharton's jelly. And Wharton's jelly is essential because moms are going to contract, babies are going to compress their cord accidentally, and we don't want any decreased oxygen. So this Wharton's jelly is like a structure to prevent compression. It's almost like insulation, so that protects these vessels for compression and helps the baby to maintain oxygenation. This is a very important schematic. You can see this is an early pregnancy. This is the end of the first trimester, mid-gestation, and third trimester. What we're looking at here at the bottom is the spiral artery from the myometrium of the uterus. So very early on, when we're trying to get oxygenation and blood supply to the baby, we don't need very much, or to the embryo. So we can see these little spiral arteries, and they just provide, up here is the anchoring villus. This is what is anchored to the uterine lining, to the decidua, and it pushes through oxygen and nutrients to this, and so very early we don't need much, but late you can see that these vessels are so dilated. They're big, they're dilated because the baby is big and needs a lot of oxygen and a lot of nutrients. So if we have any disruption here where the placenta is sitting on top, we see that we can have a tremendous amount of blood loss here in the third trimester versus the first trimester. Here's a schematic of the placenta, and you can see here the 2 arteries in the vein. So remember, babies are getting, so food, oxygen and food is going to come in through the endometrial arteries, and it is going to push oxygen and nutrients around in this chorionic villi of the placenta. Okay, it's going to push it around by osmosis and diffusion, and then babies are going to pick that up, and it's going to get delivered via the umbilical vein. Now, when babies have CO2 and waste, it's going to go into the 2 arteries, which are high pressure. It's going to get pushed out into the same fashion, and then moms are going to diffuse it and pick it up via the endometrial vein and take it back to mom for excretion. So the placenta, you guys, the placenta is a super important structure. I can't say enough about it. If you're having a malfunctioning placenta, you will not have a successful pregnancy. The placenta is like a beautiful rose. Very early on, it's immature. It continues to grow. It's just really a huge it's really an oxygen supply and nutrient supply to the baby. So if there's any problems with the placenta, we know that we can have issues. When we start to have a placenta that's functioning, or we have to have pregnancy, we're going to get a positive human chorionic gonadotropin. And that's also the test that we have when we know that someone is pregnant. This is actually a picture of the placenta. This is the part that attaches to the decidua basalis. And remember that the placenta and the uterus and the placenta do not exchange blood. all that happens is mom pushes over oxygen and nutrients to the intravillous space. Let me go back here, this little space right here, and not red blood cells, just oxygen and nutrients. She pushes it over via this endometrial artery. The baby picks up the oxygen and nutrients and carries it via the umbilical vein to the baby. The baby pushes back CO2 and waste, same way, diffusion and osmosis. The mom is going to pick it up and carry it back via the endometrial vein. So the two should never mix. There's no mixing of blood supply. You can see this is the chorion, this is the top part. You can see all these vessels. So you guys, on this placenta, what's so important is that the baby has extra blood volume and is pushing all of this blood back to this placenta, where we can have diffusion and osmosis in this intravillous gap on this other side of the placenta. So as the placenta ages, or if someone uses drugs or is hypertensive, or is having any issues, there's going to be vascular problems. And there can be calcifications in this placenta, which will prevent the baby from getting oxygen and nutrients in from this part through to the cord to the baby. So you guys, we always look at these placentas and we don't want to see white infarcts, or we don't want to see calcifications, because it's essential that baby has good blood flow to the placenta and back from the placenta to make sure that the baby gets enough oxygen and nutrients. Here is the embryonic to third trimester scale, which shows you periods of teratogenesis and problems which may occur. So we can see that this is the first 8 weeks. You guys, the first 8 weeks is the most crucial period for teratogens. And you can see we have neurotube defects, we have delays, mental retardation, we can have heart problems, upper and lower limb problems, cleft lip and palate, upper lip problems, low set ears, problems with eyes, glaucoma, hyperplasia and staining of the teeth, and then if we're exposed to some hormones, we can have masculization of the female genitalia. So you guys can see that the purple is the highly sensitive period. So the CNS continues to mature from the minute you're pregnant until the baby is delivered, all the way through infancy, through childhood. So you guys, CNS is super important, not to ever have any CNS insults ever to this developing fetus or any children. You can see that with the rest of these, it's less of a risk the more time goes on. And we'll talk about some more teratogens later. But just remember, the first 8 weeks is the most crucial period. So you guys, the fetus is from 9 weeks until the pregnancy ends, anywhere from 40 to 42 weeks. Viability means that the baby can live outside of the uterus, and we have a 20-week rule for that. There is a couple of fetal structures that the baby has that once the baby is born, these structures will close. And we're just going to briefly go over this, but remember, the baby does not breathe oxygen in utero. It breathes in and out amniotic fluid, but it's not getting any oxygen that way. So what we do is we have some bypass valves. We have bypasses so the blood does not have to go to the lungs as much. So the first bypass we have is the ductus venosus, and it is right here. So it bypasses the liver a little bit and sends oxygen. It's the first shunt, or the first duct. And so what happens is when it goes in, it just prevents as much blood flow to the arms and legs so that the central body can have more oxygenated blood flow. And you can see here's where it's coming in, and it's red and it's highly oxygenated. It's going to go past the liver via the ductus venosus, and it's going to come right up here to the right atrium. Well, the next one is the foramen ovale. So the blood's going to go, it's going to skip going to the right ventricle, pulmonary artery, pulmonary vein, left atrium. It's going to skip that. You're going to have oxygenated blood go to the right atrium, and then it's going to go through the foramen ovale straight over to this left atrium, then down to the left ventricle and out the aorta. So that's your second duct. And then lastly is the ductus arteriosus, and this one comes off the pulmonary artery and it connects to the aorta. And so these three structures will close after the baby's delivered, but the baby needs these for oxygenation in utero as it continues to develop. We're going to have a lot of system changes. We're going to have increase in fetal hemoglobin, which has a high affinity to oxygen, very different than adult hemoglobin. The GI system is developing, liver, respiratory system, pulmonary surfactant. The more the baby breathes, the better and the surfactant the baby has, and the older the baby is, the more surfactant. We can tell how much surfactant there is by doing an LS ratio to look at fetal lung maturity, and we'll talk about that a little bit more later. Obviously, all these other systems are developing as well. There's sex differentiation in the embryo around the 7th week. Usually we can tell the sex of the baby by the 20th week via ultrasound. We do have some other tests that we can tell the sex of the baby as well that are blood tests. Twins are 1 in 43, and then other multi-fetal pregnancies are 3 or more. So you guys, we have a lot of use of fertility drugs because mothers are waiting until they're older to have babies, and so we're having more multi-fetal pregnancies. This is just one where you can see here's twins, here's 2 eggs, twins, and then here's 2 fetuses that are in separate amniotic sacs, and then here is a mono-mono. Here are 2 babies, 1 placenta, 1 sac. So there's different variations of twin presentations. So congenital means this condition was present at birth. So we say this baby had a congenital abnormality. It can be from environmental factors, again, retin-A, any of the teratogens, cytomegalovirus, poor maternal nutrition. That can be because mom is not eating or mom is not getting the nutrition. Mom's hemoglobin is low and baby has decreased iron and decreased oxygenation. Teratogenic exposure and inadequate folic acid intake, which could lead to spina bifida or small brain or no brain. So just the key points: the human gestation is 280 days. We talked about fertilization occurs in the 2 within 24 hours. Implantation is at 6 days, and then the organs continue to develop. We just really want them to stay away from teratogens the first 8 weeks. It's super important. And then we have a lot of fertility drugs that we're looking at. So you guys, make sure you take your quiz. This one you can take as many times as you like, and you will be responsible for the material on your test. Thank you.